So with our Avel emergency program, we are in over 200 emergency departments. I think it's 206 this week. So, and we're in about 15 states. So we see everything from the Canadian border down to the southern border of our country. Here at Avel, we are a virtual hospital. So we have looked at the acute space really well. We cover ICU, hospitalists, so inpatients that are not ICU, but still needing to be in the hospital, emergency department, pharmacy. And so those are kind of our inpatient units, but we also take care of behavioral health, both inpatient and outpatient, and school health, so taking care of children, either have an acute problem, maybe they had an injury, or maybe they have chronic issues like diabetes and helping to keep those kids in school, as well as senior care. So helping to take care of our older population, both in assisted living and in nursing homes. And then there's just a button on the wall. So if you think about a code button in a hospital, the nurse or the physician or whoever needs help can just hit that button. That rings to our phone. And then they're able to say, I'm at General Hospital in this specific town in room 2. And then we pull that up via our poly camera. So we're able to just choose that via remote on our computer. And then that brings up video, usually within about 30 seconds, we're live. So as soon as I can see them, we can talk to each other, and I control the camera on my side. So if you are doing an airway or you're taking care of that really sick patient in your emergency department, you don't have time to go and move that camera or turn up the volume or any of that. So the remote on my side, I can move that camera, I can zoom in with my 20x lens, zoom camera. I can hear everything best when they're right by the patient's side. So I can talk to that patient, ask them any questions, or if I'm helping someone with maybe a procedure that they don't do all of the time and I have to step them through that, or if they're having difficulties, they can stay right at that patient's bedside and I can be right there with them. So there isn't an interruption. They don't have to do anything. All they have to do is hit one button and we're live. We take care of really, really sick patients over the camera. We do an average of about 3 cardiac arrests a day through our shop. And so we have to be kind of run that line with doing critical care, but also supporting the staff on the other side, particularly in our rural areas. They know these patients, their neighbors, their friends, their neighbors. And so kind of supporting them through making some of those hard decisions. So I do think that most people think of telehealth as having an appointment and going over your phone, but we really have stretched that in a big way. And we've done it for years. We've been doing this for 25 years. We are seeing those really sick patients or really complicated patients that don't come in, all of the time, particularly in rural areas. But we also have a really robust ICU program where they're taking care of intensive care patients and helping to augment the bedside team that is there with the patients. So with our poly connections, we can actually take a videolaryngoscope, which is the scope that I look into the airway in order to put an endotracheal tube down someone's airway to help them breathe. I can actually see what that physician on the other end is seeing. So if it's a difficult airway, they're having trouble placing that tube, I can talk them through it. So I can say, it looks like you're a little bit deep. I think if you would lift up from here, maybe give a little bit of pressure here, kind of talk them through what they would need to do. Having now delivered probably more babies over a camera than I have in real life, what happens when you're trying to then care for that baby that's on a warmer is that all you can see from the camera is the back of everybody's head who's around this really small little baby. And so Our regular cameras weren't able to see on that warmer, so I wasn't able to really look. And we had that same issue with our neonatologists or our neonatal ICU specialists when they were doing this kind of work. So with our innovation team, we had to think about it differently. How can we look down on this patient, but not be in the way of the bedside team that is going to care for these really vulnerable new humans that are just new to our planet. So we were able to take a camera and mount it on the warmer, which you have to think cameras and warmers and humidity, all of that had to be taken into account when we're trying to innovate and look at how do we take care of these patients. But then being able to bring that into the feed was really kind of a special thing to get figured out and has been really helpful in that population. What is, I think, exceptional in the way that we do it is that the technology fades to the background, which is what it should do, right? It's so important, but as a clinician, I take care of really complex patients, and I don't want the technology to be complex for me. I want it to absolutely do what I need it to do so I can see what I can see, but I don't want to have to, have a degree in the technology. And we've set this up in a way that has been really easy. My job here is a lot of medicine and honestly, not a lot of technology. It really does fade into the background. So technology has been phenomenal, and every year we come up with new ways to use it in ways that we haven't thought about before. So kind of just stretching our minds around that. One of the things that we saw with COVID is that if you gave people the resources, they could do so much more than what they ever thought they were capable with. And one example of that was adding a respiratory therapist to our program. Because most of our rural areas had never used BiPAP and certainly had never used heated high flow, which are two uses, oxygenation uses that we use a lot in COVID. And so all of a sudden, all of these rural hospitals had BiPAP machines and they had heated high flow, but they needed support to use them. So we gave them a respiratory therapist that could help titrate these medications. And we were able to keep a ton of patients in rural areas and leave our tertiary hospital for those sickest of the sick, the patients that needed to be intubated, needed to be in an ICU, needed that higher level of care, or maybe needed dialysis or whatever they needed, surgery. And so giving them that extra help helped us actually to manage our surge because we were able to keep more patients local where they wanted to be anyway. So I think, necessity was the mother of invention throughout COVID. And I think it was the necessity of innovation too, where we had to figure out, okay, how can we help, our very capable nurses and physicians that are in rural areas. And I had a family physician who is probably been a physician for over 30 years. And he said, I was able to keep patients I would have never kept before. And I felt very comfortable with it because I had that resource with respiratory therapy. And I knew that if that patient got sicker, then we could move the patient. So working with our team to figure out when that patient would need to move if they had to, or could we keep them there? So I think all of that has been innovative, life-changing, and actually has been really good for rural healthcare.